Welcome to the Practicing Clinicians Exchange podcast, transforming the care of patients with non-small cell lung cancer, optimizing immune checkpoint inhibitor therapy. Today's episode features Beth Sandy, a nurse practitioner from the Abramson Cancer Center at the University of Pennsylvania in Philadelphia, Pennsylvania. Ms. Sandy will summarize key updates and practice-changing data from the 2022 American Society of Clinical Oncology ASCO conference related to immune checkpoint inhibitors in advanced NSCLC. After listening, please visit pce.is/ONC22 to access the slide sets from the recent PCE Oncology Conference and additional related activities, including a series of interactive patient case simulations focusing on the use of immune checkpoint inhibitors in the care of patients with advanced NSCLC and managing immune-related adverse events associated with these therapies.
Hi, everyone. I am so pleased to be here, and thank you to PCE for inviting me to do a podcast on updates from ASCO 2022 in non-small cell lung cancer immunotherapies in the advanced setting. This is a topic that's very near and dear to my heart, so I'm excited to talk to you about some of these ASCO updates from some of the abstracts. So the first one that I'm going to talk about is the 9LA regimen and the 3-year update. So, this is a regimen that's been around in metastatic non-small cell lung cancer for years now. This is the one that is ipilimumab and nivolumab plus 2 cycles of chemotherapy. And then we drop out the chemotherapy and just keep going with the ipilimumab and nivolumab. And this is nice for patients who want to be spared of chemotherapy and only have to do a couple cycles and then just go on an immunotherapy only regimen. So now we present the 3-year update. So we're starting to get some more durable data on this. And one thing that we found is that 37% of patients with PD-L1 negative disease, so these are the typical patients that often need chemotherapy to help them respond to immunotherapy. In that setting, 37% of these patients of PD-L1 negative have ongoing responses at 3 years. And I'll tell you, there are none of them on the chemo alone arm on this trial that have ongoing responses at 3 years. So this is really interesting because, we always think of immunotherapy working better for these PD-L1 positive cohorts of patients, and it does generally, that's true. But what we're seeing here is even these patients at PD-L1 negative disease, whether it's adding the ipilimumab to the PD-1 inhibitor and only requiring 2 cycles of chemotherapy, there's a significant number of these patients still having ongoing response at 3 years. And again, that was 0 with the chemotherapy arm only in this trial. Interestingly, of the PD-L1 positive, which was considered 1% or higher, 18% of them still have an ongoing response at 3 years, which is still a good number, but oddly lower than the PD-L1 negative cohort. So again, very interesting data here to parse out, but showing that there's certainly a longevity for a certain cohort of these patients. If you look at the 3-year overall survival, it was 27% for the patients on the ipi-nivo plus chemo arm, as opposed to 19% on the chemo-only arm. So there's certainly an advantage there. Again, just to remind the audience that talking about 3-year survivals for stage 4 patients with non-small cell lung cancer is something we really didn't talk about before the era of immunotherapy. So exciting data for longevity here. Let me move on to the next one. Another big one is the Checkmate 227 5-year update. Again, these are long endpoints that we didn't used to talk about when I started doing lung cancer 20 years ago. So this is exciting. Now, as a reminder to the audience, this is a clinical trial that was looking at ipilimumab and nivolumab versus chemotherapy. So one interesting statistic that we were able to see here in this trial is something called a treatment-free interval in the 5-year survival. So what does that mean? That means patients probably in the study, they got their ipi-nivo and maybe they stopped because they stopped at 2 years, which a lot of us did on clinical trials with immunotherapy. Maybe they stopped because of toxicity. For whatever reason, they stopped but did not have progressive disease. And what we found in the PD-L1 positive cohort, again, positive being 1% or higher, is that 66% of patients still had a treatment-free interval at the 5-year mark. Now, again, it's kind of confusing of what that means. And I think the average here was that they got 4 cycles of ipi-nivo, is my understanding. So now again, these cycles were longer. These are like, I think, 6 to 12-week cycles. So they're long cycles. But what I'm saying is these patients weren't on treatment for years and years and then only stopped for a year. These patients were on study for maybe 6 months to 24 months and then stopped and haven't had to restart chemotherapy. So that's really exciting. And then interestingly, sort of like we saw in 9LA, in the PD-L1 negative group, 64% also had that same treatment-free interval in those 5-year survivors, in the patients that are alive at 5 years. So it's obviously not the entire study, but of the patients that are alive at 5 years. So what that means to me is, again, the addition of ipilimumab to nivolumab seems to be somehow, there's some kind of synergy there that is allowing patients to have these durable responses and even go off treatment and continue to maintain those ongoing responses in that 64 to 66%. So that's really exciting. And 4-year overall survival in this study was 29% in favor of that ipi-nivo arm. Again, that was a non-chemo arm. And the grade 3/4 toxicity was 44%. So again, kind of getting excited about this regimen a little bit, but I am reminding you there is certainly toxicity. But we sort of see this idea as if you can get them over that toxicity hump, they tend to do very well. I wanted to bring in, I know this is kind of out there, but there was a melanoma trial called the Checkmate 067 trial. And that has the longest data because I was kind of going back and thinking, okay, what is this ipi-nivo? It has long data. So I looked at this trial and they have a 7.5-year follow-up right now in that Checkmate 067. And 48% of those patients on study are off of treatment. 77% never had to have another treatment. That is incredible for metastatic melanoma, which was absolutely a death sentence 5 to 10 years ago. Again, this study had that median of 4 cycles. So people were either on it somewhere between 6 months and 24 months, and then were off of it. So sort of similar. I know they're different diseases, but I hope that lung is on that same trajectory as melanoma, because that would be really exciting. So those are the kind of the long-term updates of those 2 ipi-nivo trials that were really exciting. And so while I'm talking about, these ipilimumab and nivolumab trials being durable responses and exciting data, I will remind the audience, certainly the addition of ipilimumab to nivolumab causes increased toxicity. Like I was saying, the grade 3/4 toxicity in 227, the Checkmate 227 trial, was 44%. It's pretty high. So what I want to remind you is, especially in lung cancer, pneumonitis is going to be at a much higher rate. I'm going to talk about that in a couple of the other abstracts coming up. But, the pneumonitis rates can be upwards of 10 to 20% in patients with lung cancer, especially when you're adding and combining these 2 checkpoint inhibitors. So be very careful about looking out for that shortness of breath, hypoxia, persistent cough in patients. In lung cancer, we don't see as much of the rashes that they do in melanoma, but that's certainly another one that can occur at higher rates. And then all of the other inflammatory conditions. It is important to remember to keep checking labs on these patients every 3 to 4 weeks, because, some of these regimens, patients are only coming in every 3 to 6 weeks. Make sure you're getting labs every time, because that's where you're going to catch the immune-mediated hepatitis and nephritis. Remember, they're not going to come in jaundice from immune-mediated hepatitis. That would be if you missed it for like months. These are things that you're going to see on a lab report. You can see those AST and ALTs skyrocket from normals of 50 to like 400 and 500. When they go up that quickly, that's usually an immune-mediated response, and same with nephritis. So make sure you're monitoring labs, certainly monitoring their shortness of breath, which is more common in these patients with lung cancer, monitoring for skin toxicities, because these will happen at higher rates than they do in other solid tumors. All right, the next abstract that I want to move on to talk about is an updated analysis from the ATEZO-BRAIN trial. So it is what it sounds like. It's atezolizumab plus carboplatin and pemetrexed in patients with advanced non-squamous non-small cell lung cancer with untreated brain mets. Now, this was an interesting abstract to me because historically, we really have not seen good intracranial penetration from certainly chemotherapy, nor IO for the most part. We see this with some of our targeted therapies, especially EGFR and ALK inhibitors, but not nearly as much with immunotherapy. And so we hesitate to leave untreated brain mets sometimes in these patients. But this was a 2-year update that was prospectively looking at these patients with untreated brain mets. So this was a cohort of 40 patients with brain mets. 22 of them were on dexamethasone. So this also brings in that question of, does dexamethasone somehow decrease efficacy of immunotherapy? And 20 patients with were PD-L1 positive. I will tell you that 16 out of those 40 patients, which is 40%, did have an intracranial response, which again is very interesting considering that we have not historically seen a lot of intracranial responses from chemoimmunotherapy. And then 47%, so a little bit more, 19 of the 40 patients had a response, a partial response in their body, which seems right. That's about more typical of what we see with chemo IO. Now, one thing I will say about these patients, again, they had untreated brain mets, but to be on the trial, you could not have any neurologic symptoms whatsoever. And you had to be on less than 4 milligrams daily than dexamethasone, less than or equal to. So honestly, that's not that much dexamethasone. So I think technically, if these patients truly had edema and brain mets, they'd probably require more dexamethasone and we'd probably be treating. So that's the only thing I'm going to say about this trial is that while these are untreated brain mets, these are probably small, very asymptomatic, not requiring much on the way of steroid brain mets. So it is a generally better population than your average run-of-the-mill brain mets and lung cancer, probably. One other thing to point out on this abstract was that there was no difference in overall survival between patients who were on dexamethasone and not on dexamethasone. So that, again, gives us kind of this level of comfort that probably all right to have patients on low doses of dexamethasone here and there, or prednisone for that matter, and it doesn't seem to affect overall survival, which is what we've seen in other studies with immunotherapy. Again, they were low doses. You could only be on 4 milligrams or less of dexamethasone to go in the study. So interesting. Okay, the next abstract I'm going to move on to is a 2-year update from the Keynote 799 trial. This is pembrolizumab plus concurrent chemoradiation for unresectable locally advanced stage 3 non-small cell lung cancer. So this is in the locally advanced setting. So these patients received concurrent chemoradiation plus pembrolizumab, and then that was followed by a year of maintenance pembrolizumab, which is sort of going with what the standard of care right now is with the Pacific trial, where we do a year of durvalumab after chemoradiation. So this was adding the pembrolizumab to the chemorads, followed by a year of pembrolizumab. Mostly so far in this study, what we're seeing reported is response rates. So the median progression-free response, they had a squamous arm and a non-squam arm. So the squamous arm got paclitaxel and carboplatin with the pembrolizumab every 3 weeks. Their median progression-free survival was 30 months, and it was not reached in the non-squam arm, which was getting pemetrexed and platinum plus pembrolizumab every 3 weeks with the radiation. So that's not reached, which is good, though the follow-up at this point is only a 2-year follow-up. This abstract or this study definitely needs more time to develop the data here. The overall survival at 24 months at 2 years was 64% in the squam arm and 71% in the adeno arm. And that's about standard of what we were seeing with the current Pacific data. So that's about the same, I would say. One thing I will say is that grade 3 pneumonitis was 8%. So grade 3 is severe. You can't re-challenge it. So the majority of pneumonitis we see in grade 2, but there was 8% grade 3 pneumonitis. So you can certainly get some severe pneumonitis with this to be aware of. Okay, the next study I'm going to talk about is consolidation nivolumab plus ipilimumab or nivolumab alone following concurrent chemoradiation for patients with unresectable stage 3 non-small cell lung cancer. So here we are back to this space of concurrent chemoradiation with curative intent in the locally advanced setting. Now, again, reminder, the standard of care right now, approved agent, is durvalumab in the Pacific trial. This is looking at giving concurrent chemoradiation as they did in Pacific, but then going with ipilimumab and nivolumab or nivolumab alone post-chemo rads, but only doing it for 6 months. So that was the hitch here. This trial is looking and saying, can we shorten that interval instead of a 12-month post-chemo radiation immunotherapy? Can we do just 6 months? This trial looked at 105 patients. Right now, their follow-up at 18 months, the progression-free survival at 18 months is 62% on the nivolumab arm. The ipi-nivo arm is 67% progression-free survival. So those are actually fairly good numbers. And I was going to tell you I looked this up in the Pacific trial, and I think it's actually 66% in the Pacific trial. So these are kind of right on par there. The median overall survival is not reached. But one thing of note here that I will say is that 82% of patients were alive at 24 months on the ipi-nivo arm, which is actually pretty good. That's higher than what we've seen in the standard of care. So this is interesting. 52.9% of patients had grade 3 toxicities on ipi-nivo, though. So grade 3 is generally something we won't re-challenge. So, and 20 to 29% of those, depending on if you were nivo or ipi-nivo, were pneumonitis. Now, that was in all comers. That wasn't grade 3. I'm sorry. 20 to 29% were developed pneumonitis at any rate. In the Pacific trial, that was 34%, just as an FYI. So that's about where we were in that trial. But 52% or 53% almost did have grade 3 adverse events on the ipi-nivo arm of this trial. So I was not able to parse out what exactly all of those were. I'm sure some of it was pneumonitis, but certainly there was other things. So is this too toxic, or is this something that we could shorten the interval at 6 months? Again, the data needs to mature over time, but this is something to certainly look out for. 82% alive at 2 years is not too shabby. If those numbers hold up, that would be really exciting. So we'll see. We'll look for updates on this trial. And then the last one I want to bring to you is something called the NADIM trials. This was the phase 2 trial that then led to the neoadjuvant nivolumab and chemotherapy versus chemotherapy trial in non-small cell lung cancer, which has now become a standard of care just recently in the past 3 to 6 months because of pretty staggering responses for the nivolumab plus chemotherapy arm in this neoadjuvant Checkmate 816 trial for patients who are planned to go to surgery. Now, this NADIM trial was the phase 2 that led to that. So there was data here, but what they were looking at, particularly here in this abstract at ASCO, was the pathologic response rate. So remember, we get excited about this in lung cancer because you can give somebody chemo plus or minus immunotherapy, then take them to surgery, and you can actually tell, is there any cancer cells left? We don't get that in the metastatic setting. We just look at CAT scans. So this is kind of something that we'll say, hey, really, how much did they truthfully respond? So these are some pretty interesting data here. So the pathologic complete response rate, which means at the time they went to surgery and they took out all their lobe of their lung and their lymph nodes, there was no cancer left. Pretty impressive. So the pathologic complete response rate for the chemo and nivolumab arm in this trial was 36% versus only 6% in the chemo alone arm. So that's pretty exciting. And this was an 87 patient cohort. There's also something called MPR, which is major pathologic response, which means there was less than 10% of the tumor left. We saw that in 52% of patients on the chemo and nivolumab arm as opposed to 14% on chemotherapy alone arm. And then any response, basically, overall response was 74% versus 48%. The chances of you making it to a definitive surgery, meaning a total surgery where there was not any cancer left behind, was 91% versus 69% on chemo alone. So again, certainly a benefit here, sort of something we already knew, but to be able to say those complete response rate of 36% is actually pretty impressive. So that's nice to know. The toxicity for grade 3-4 adverse events certainly was higher. So 24% of patients had grade 3-4 adverse events on the chemo and nivolumab arm, as opposed to only 10% on the chemotherapy arm. So again, here, just like the other trials, what we see is some increased toxicity. But I think, us as advanced practice providers, this is up to us to be able to know these toxicities, catch them early, and manage them. Because certainly, while there's an increased toxicity, we are definitely seeing some increased benefit here. And, for some of these trials, we need to wait and see how long these numbers hold out. And if they are better than standard of care, this may be practice changing in the future. So really exciting stuff. Stay tuned. I'm sure we'll have more updates over the next year. Thank you so much for having me.
Thank you so much for listening today. We hope you enjoyed this podcast and invite you to participate in other activities related to the PCE Oncology conferences by visiting pce.is/ONC22.